So, hello guys, welcome to the MedEd Clinics. So, as you all know, we have started recently this clinical corner for the third and fourth prof students. So, today I'm going to tell you about the orthopedics history taking. And so, this class, what I have brought you is examination of bone and the joint injuries in a great detail, but not specific to a particular joint. It is the general examination. General, how do you take a orthopedic case? So, maybe when you enter into your third prof, you will get exposed to the orthopedics department. So what we have is whenever you come into fourth prof, so here we give you the short case for presentation, and that is usually given during your practical exam. But now maybe I have heard that from third sim people are being exposed to orthopedics these days. So what we have thought is we are here, and we thought maybe this clinical knowledge will help you to understand the orthopedics in a better way before you enter the department. So I hope this class will be useful to all the people who want to take a short case in orthopedics, but regarding to can be pertaining to any joint. So before starting the class, just read this quotation because this was always, catching the attention of mine. It was usually displaced in our general medicine department college. So this is a very, very sensitive quote that it is a very deep quote. It says that study the phenomenon of a disease without books is sail and at sea, while to study books without patience is not go to sea at all. So what it means that you can just understand medicine by looking at the patients, but sometimes you know what you don't know what to look at, what to understand. It is like uncharted. There is no direction, but you keep sailing in this. But reading just the books without patience is not going to the sea at all. So hope you have understood it better. That means you have to understand this was quoted by Sir William Octa. By this, I think you can understand how important it is to interact with the patient, to go to the wards, to engage with them, to understand their problem, and to diagnose what is their problem is actually art. So as they say, medicine is an art. So here we want all to master this art, then taking the case properly, the history properly, examining individual in detail diagnosis before you arrive at the diagnosis based upon investigation. Right? So let's see what is there for ortho. So as I've told you that today we are going to deal about the joint and bone injuries. So any history, I mean like any case taking, any department, it always starts with history taking. So as soon as the patient enters into the clinics, or maybe or you go to the bedside near the patient, it should always start with the patient. So it is utmost important. So whenever you are taking a case, you're talking with the patient, you're touching a patient, always remember this one thing. You have to always explain the patient who you are, so and so. So whenever you meet a patient, we have to introduce ourselves, like telling that I'm Dr. Alekhya, orthopedic consultant, here to check your so that it will help me in the diagnosis. That is very, very important. And why it is very important is when you want to go to other exams, like you want to crack USML, you want to go for PLAB exam, or you want to take MRCS after your ML. So all these have this practical exam, right? So there, the first thing what they see is how are you interacting with the patient. They just say hello. So how are you interacting? Interaction of the patient usually starts with telling about yourself, right? You have to tell about yourself, what you are, so and so. And then it starts with asking their name. So it actually, any patient history taking should always start with asking their name. So you have to introduce yourself and then ask them their name. There's nothing to derive from their names, but it is very, very important that it gives the psychological confidence both to the patient and to yourself. You get familiar with the patient, right? But next thing what I'm going to ask is the age. This is very important. This uh, knowing the patient's age will not only help you to arrive at certain diagnosis, especially in ortho, because in ortho we have certain diseases, genital diseases which can develop at birth, and we have certain set of degenerative disease, right? So what is a degenerative disease? Degenerative disease is a disease of wear and tear. That means usually it is seen in the old age. So when they say the patient is about 65 years, 70 years, and now they're complaining about the knee joint, so immediately you can diagnose it as osteoarthritis, right? You can diagnose it as osteoarthritis, like that. So the age becomes an important factor, especially in our department, right? Especially to diagnose this degenerative disease. For example, if it is a male patient, if it's a male patient and he's complaining about hip joint pain, he's complaining about hip joint pain, and then you have come to know that he's an alcoholic, then you can think of certain diseases, right? Such as avascular necrosis, right? Again, young male patient complaining about knee joint pain. You know, it is frequency is nowadays. You can think about hemophilia, right? So when it is young, you can put him into certain category. Again, if it is a very young patient, like for example, take 5 to 7 years of age, 5 to 7 years of age, and now they're complaining about, you know, fever and then pain. So you can think about acute osteomyelitis, right? And especially whenever we are dealing with tumors, the age become even more important. Whenever you're dealing with orthopedic oncology, the tumors, the age becomes an important factor, because we all know that whenever they talk about GCT, it is only about after the closure of the epiphysis. So when do the physis close? After 18 years. So GCT is a disease of second decade, right? And when they want to talk about multiple myeloma, so when they want to talk about multiple myeloma, so multiple myeloma is usually seen in old age, that is above 60 years, right? Similarly, metastasis also, it is seen after the age of 50 years, right? In older group also, this is very common metastasis. Again, if they want to talk about Ewing sarcoma, if they want to talk about Ewing sarcoma is also very common in the first decade, right? So this way, the age becomes very, very important. So these are certain examples for making you understand that age is somehow important in our department, that is in ortho, right? Then coming to the sex, that is the gender. So male or female. So let's stick to this part of male and female only, not going to other genders. So male and female, what do you think? Is it really important for us in ortho? Or do you think it is okay? So it becomes important when we talk about certain diseases like inflammatory diseases. For example, if you want to talk about rheumatoid arthritis. So rheumatoid arthritis and inflammation is because it is an autoimmune disease. As we all know, autoimmune are mostly in. So now, whenever a young female comes to you, or a female of 30, 40 years, mid-age, comes to you, coming with polyarthralgia. So she complains of polyarthralgia. What is the meaning of polyarthralgia? Polyarthralgia meaning, so multiple joints gets involved. So whenever you see a female patient with multiple joints, your first probable diagnosis would be rheumatoid arthritis. So we commonly diagnose rheumatoid arthritis in females, right? And in case of males, if a patient is alcoholic and again if he's complaining about first metatarsal joint, first MTP, then you can think about very common gout. You can think about gouty arthritis, right? So that way, again, the gender becomes an important thing for us, right? So name, we have got familiar with the patient, then depending upon the age we can decide whether this is a degenerative disorder, whether it's a traumatic disorder, or whether it is an infection or tumor, to certain extent. And then depending upon the gender, few diseases again can be divided, such as, you know, inflammatory diseases, very common in males. And then males, usually the first MP, whenever it is involved, painful, you can, which results in your gouty. arthritis, right? And then comes to the occupation. Do you think occupation is really important for us in case of ortho? Yes, somebody thinks occupation is important. What do you think? Occupation? So what happens here is, yes, occupation is very, very important in case of ortho because most of the orthopedic problems are mechanical problems. Mechanical matlab you keep changing the postures whenever. Now, for example, I'm sitting in the chair and I sit like this, then my back aches, right? So then they come with pain in the, then we work for a longer durations all of a sudden, and then they come with, pain in so and so part. And then, for example, people who are very enthusiastic for the fitness, right? When the Jan 1st comes, they think they have to do all sorts of exercises on Jan 1st. They suddenly decide and then they go to gym and without proper warm up, they do all. So that is again related to the mechanical overload to the muscle. So that is again part of, again, they come to the OPD with the pain. So it is not related to occupation, but what I'm trying to tell is most of the mechanical problems are related to their occupation. For examples, we have certain bursitis, such as your housemaid's knee. So, housemaid's knee, the name has come because the housemaid who keeps sweeping the floor is all flexing the knee continuously. This will irritate the which bursa? The prepatellar bursa. So, the prepatellar bursa will get damaged and it will result in the bursitis. So, that is how housemaid's knee comes. So, that is how occupation is, right? So, and student's elbow. Student's elbow is what? Student's elbow is olecranon bursitis. So, this part, the student continues their hand over the table, and this, the friction olecranon will result in the olecranon bursitis. So, that is again student's elbow, right? So, that way, this occupation is also very, very important to us, right? And for example, if a patient comes with a swelling in the foot and he happened to be army personnel, and this is again related to what? It is related to the stress fracture, march fracture. So I subsequently will tell you what is march fracture. So like that, somehow occupation is very much related to orthopedics. So you have to definitely understand what is their daily work schedule, that is what is their occupation, right? And then of course residence. So this is the address because of the locality for some disease, like for example, when we go to places like Nalgonda in Telangana, there is an excessive fluoride levels. So you can think about certain diseases like fluorosis. So that is how residents. So these are the petty examples which I've quoted, but usually we can derive much from the demographic data, that is the name, age, gender, occupation. So I have quoted certain examples related to it. Hope you will understand how important it is. Okay? And then coming to the actual orthopedic history, like actually taking case of orthopedics. Till now, we are in the general details of the, right? And now coming to the orthopedic case taking. So the first one in any, like in any other department, it is taking as usual. You have to take the chief complaint in history taking, right? And then you have past history. The chief complaint, it is history of presenting illness, right? So, usually what happens in ortho is we are talking about a small case here. So, small case is something which we don't take in a great detail. The history taking will not be in a great detail. Like in the general medicine or general surgery, we have certain parts of history, like from history of presenting, past history, the drug history, and then we have the personal history. So, here in ortho, because it is a short case, what we take here. So here we start with a chief complaint and a brief history of presenting illness, which includes all the details of that particular illness. and then past history we have, and if some relevant points are there, only the positive ones we take. Okay, the positive points which you want to add on, like if the patient is really obese, you can put up patient is important. And then if you want to tell a certain personal history, like if the patient has for a long duration, which can be attributed to your diagnosis, so you can quote that as smoking history. But usually we don't tell that there is no history of smoke, there is no history of that, there is no negative history. Remember that, no need of negative history. But again, certain important negative histories can be added depending upon your case. As of general thing, there is no negative history which is required, all positives put together, but few important negative points. For example, if you want a patient to tell about infection, and if you want to rule out the tumor part, so there you can add the negative history has no of weight loss. It is very important for tumor, seeing the tumor, and no history of loss of appetite, something like that. So very, very relevant negative history can be added, and this should be very brief. So first your chief complaint, then history of presenting illness, then your past history, and some all the positive points. If all the in other histories, if you want to put up, put the all the positive points, and very, very important negative history only if it is required to tell the particular diagnosis, right? So that is about the history taking. And then local examination will be little elaborate, even though it is a short case, because there are certain steps for local examination which you have to follow. And then comes to the probable diagnosis. And then they will ask you about the management, where you will tell them regarding the investigations. And then if they provide you with the certain investigation need, then you can the definitive diagnosis. Okay, so this is how the flow goes. So first is demographic data. So these all you're going to ask them. So first is the name, then the age, gender, occupation, and the locality or the residence where they reside. And then comes the history taking. So history taking will always start with the chief complaint, right? I know, I assume that you are all very aware of what is a chief complaint. Chief complaint is that important complaint for which the patient has come to the hospital. There may be other relevant points, but the chief complaint would be very, very important point. So for that particular issue, the patient has come to the department. There may be a long history for that complaint, but it should be in a one sentence. So usually we end up this complaint in one sentence. So in our department, what could it be? It is usually history or patient has presented with the history of pain in the hip joint, right? Since very important, the timelines are very, very important in case of your chief complaint and presenting illness. So probably say some 1 month or 1 year or 2 years. Okay, so what has made her to come to the hospital? Because hospital is a place where nobody wants to go, right? Do you want to go to a hospital daily and meet doctor and come? It is not a source of entertainment or something like that, right? We only go to the hospital whenever we are actually very much pain. We want a solution to our problem. So that problem, that particular important problem has to be treated as the chief complaint. And now whenever you put complaint as hip joint, and if the patient is also having a knee joint pain. So first in the history of presenting illness, you talk about the hip joint, and then you come about the knee joint. So first point should be elaborated in detail, and then come to your second point, right? So that is how you take the history. That is the how you take the chief complaint also. That is how we also respect the timeline. So if the hip pain is since 1 month and knee pain is since 1 week. So first we put the hip pain since 1 month, and then we put knee pain since 1 week. So this is called the chronological order, which is very, very important to follow while taking the chief count, right? So I hope you all know this basics, because this is how we take history in case of your general medicine and general surgery, any other gynec as well. Okay, so that is the chief complaint and history of presenting illness. this heading, like if we start with hip joint, then you have to go about the hip joint. So what do you describe there? So as you all know, again, I'm specifically telling that in case of ortho, what happens is age becomes a very important thing. So why age is very important? So we have already discussed there are certain genital diseases or developmental diseases, and there are certain degenerative diseases. So in ortho, what happens is we can divide them into certain subtypes. So based upon the patient history directly, you can tell which category this patient belongs. For example, if a mother comes with a baby telling that, there is some deformity in the limb since birth, for example, CT. So directly you put this under a congenital disorder, right? And again, I have to that if a patient comes with the pain in the knee joint, if that particular patient is above 75 years old, you can tell it is a degenerative disorder. This is a broad aspect, right? And there are certain again diseases like inflammatory. Then we have a set of infective. Then we have metabolic. Then very important trauma. And then we have that is oncology. So in ortho, basically you can divide the patient areas, right? So if a patient is belonging to particular age, and then depending upon the next important thing, that is the mechanism of injury, you can put the patient into certain category, right? Kalai, good evening. Tejasvi has put up good evening, but again, I think she has deleted that message. So these are the broad things. I want you all to take a screenshot or write it somewhere, because this is very, very important. So you see a patient about, for example, say 45 years, and I've told you it is a female, and now multiple joints involved. So thinking about inflammatory. So directly you can go to inflammatory. Inflammatory, we have very important rheumatoid arthritis, or we have other diseases, like there are set of diseases where you can diagnose it a little easily. And if you think there is a 65 years old female with pain in the knee joint, so you can think it as osteoarthritis. Then there is a 8 years old kid with pain in knee, associated with fever, raised ESR and CRP. Or you can put that patient into infect. Then you have bow legs. If a patient comes with the deformity, bow legs, right, you can put into metabolic disorder, right? And then whenever the patient comes with the history of fall, history of very, very important in ortho, right? The bread and butter of orthopedics is trauma, right? So fractures, dislocations, these all comes under your trauma, right? So when you want to deal with fractures, dislocation, and all your sports medicine, like your ACL injury, your PCL injury, so all this comes under trauma. So there will be a history of fall, there will be a history of injury. So that is, and finally, last but not the least, very, very important is your tumors. So this patient, again, based upon the tumor, based upon that particular tumor, there are various complaints, like patient can come with pain, can come with swelling, can come with important, that is the logical fracture, right? So they can come with fractures also. So those fractures in tumors are as pathological fracture. So this is a broad aspect of ortho. So once you understand this particular slide, no, you can, ortho becomes very, very easy. So I have put this because age is very, very important. Because one is, the bone strength decreases. You all know patients suffer with osteoporosis. They grow from child to adult. So the bones become weak. And why it is very important, the age, again, it is also important for the treatment part. So for the treatment part, becomes very, very essential, because again, I've told you, so most of the patients in older age, they suffer with osteoporosis. So again, treatment also differs based upon age. And what is the classical example where age plays an important role in case of treatment? Very important. Your IC. So what is a IC fracture? It is a type of hip fracture where the head of the femur breaks, right? And that depends upon the age. If it is patient is less than 60 years, there is a particular treatment. And if it is more than 60 years, there is another type of treatment. That is how age is important. So less than 60 years, more than 60. So age becomes a very important criteria for the diagnosis and also for the treatment, right? So, and again, this is the X-ray of the patient. You can see the difference, how developed is the adult bone with the, different types of epiphyses, meta and dia. And here you see the small bones, right? Developing bones. And if you think this particular patient is complaining of four legs in children, then this is called of rickets, right? That is decrease in the calcium and the vitamin D. And same thing when happens in the adults, it is called osteomalacia. Same thing, same decrease in vitamin D and decrease in calcium, serum calcium. That is your vitamin deficiencies in case of adult and children. So just to make you understand that how much age is very important in our history, right? So that is about the age. Then I have told you one more interesting thing in case of history. Whenever you talk about history taking, the one thing which is very important in case of orthopedics is injury, the trauma. And once if the patient commits that there is trauma, fall or an injury, you have to assess what is the mechanism of that particular injury. So you have to know how severe is that injury, is the violence of the injury. So you have to know whether it is a violent injury, is a simple fall, a trivial fall at home. What do you mean by trivial? Trivial fall at home means just fall from the standing height. The exact definition is fall from standing height. So patient has been walking and suddenly slips. So that's trivial fall. What is a violent fall? Fall from somewhere else. So there are different types of fall put up here. So they fall from stairs, they fall from a height, they fall while running, while jogging. There will be a lot of injury. So you have to greatly ask them what was the type of the injury. Committed that they have come with pain in the hip joint, and then if they say there is a fall, then directly the diagnosis will go into trauma. If they are coming with pain in the hip joint but there is no fall, there is no, then you have to think about whether it could infect or degenerate. Okay, so that is how your thought process will be going on in case of orthopedic history taking, right? Any doubts you have? Am I going fast or slow? Okay. So once the age factor is done, then we have this. I have told you that trauma and this mechanism is very important. And first thing you have to ask whether this was a direct injury or a indirect injury. So what do you mean by direct or a indirect? Direct injury is direct clash to that particular body part. For example, in the knee joint directly fall onto the ground touching the knee joint, so there will be a transverse fracture. For any direct, they usually there will be transverse fractures, especially the patella, right? Right. And if this direct is okay, thank you. So if this direct force has been, even a stronger force has been applied, so direct with increased force, then this could result in what is called as comminuted fracture. What do you mean by comminuted fracture? Whenever there are fracture fragments of more than two fragments. So once there is a fracture and you will find the fragments, right? The pieces of the fracture. If they are more than two fragments, then that fracture will be a comminuted fracture. And when you see a comminuted fracture on the X-ray, you know that this particular fracture is the high force. So there will be a high force or high violence which have been involved in this injury. And indirect forces. What are the indirect forces? So these twisting forces or bending forces, where which will result in oblique fracture. So whenever you see the X-ray and you see an oblique fracture with the butterfly, with or without butterfly, then you can think these have happened because of the indirect force, right? Because of the indirect force. Again, if this indirect force is very high, again it will result in your comminuted, results in your combination, right? So this is how the age and the mechanism of the injury is very, very important, right? Again, if the mechanism of injury is little at a lower pace, for example, if the patient in these steps and there is a twisting of the ankle, usually they come, right? Females, whenever they wear this heel, they keep climbing and suddenly there will be twist of the ankle. So this is not a very high force when compared to a road traffic accident or falling from the steps or falling from a height. It is a direct it could be a direct force or indirect force, but of a low velocity, right? The velocity is important. So that time you can diagnose it as a sprain, right? What is a sprain? Sprain is a problem in the ligament. So whenever the ligaments are involved, not the bone, then you can call it the sprain. So usually they will tell now, like we had ankle and all. So that is because they have some problem with the ligaments, right? Is that clear? So that is how important is the mechanism of the injury. So first we are going to inquire about the age. So it helps us for the diagnosis and also for the management as we have seen. And then we have inquired about the mechanism of the injury. When they say there is age has been done and then they say injury. So if the injury is present or trauma is present, then it is trauma case, directly injury. And if there is no injury, then this becomes cold orthopedic. What do you mean by cold orthopedics? So where you have this metabolic disorders, where you have the tumors, the inflammatory, the infections, all are cold. Is other, right? So in orthopedics, we have two sets: one trauma, cold orthopedic. Trauma is nothing but, as I've mentioned, is related to fractures, dislocations, and about your sports injury, sports medicine, like your ACL tear, MCL tear, your rotator cuff tears in the shoulder. So all this comes. Cold orthopedics is infections, inflammatory, degenerative, metabolic tumors, right? So that is how age and injury is important. So once they have said that there is an injury present, then you have to decide whether it was a high force or a low force. So as I've mentioned that high force will usually result in fracture and dislocations. Low force will result in sprains or some hairline, right? So that is how the velocity is very important. High velocity or a low velocity injury. That means high force. Usually high force example is road traffic accident. Low force is, as I've told you, the word trivial. Okay. And now there are certain set of fracture. Very important. So if you can identify here, there is a fracture. So this is the fracture. So this fracture I'll describe. So this is in the second metatarsal. And in the neck, if you can see, because this is the head, neck, and the base, right? So we are seeing this particular fracture in the neck. So neck of the second metatarsal fracture this is. And what the patient has told is this is because of low force. And he has told that this has occurred. I mean, he is a soldier and he has recently joined. Yes, very good. So, based upon the history, so this is how it is history, right? So, I have told you that this is a low force injury and the patient is related to army. And if you say, whenever I say low force and there is a fracture, so this could be a stress fracture because here you see on the X-ray, bone is normal, right? So, repeated forces in a long bone or a normal bone, repeated forces in a normal bone will result in what is called as a stress fracture. So this is an example of your arch, right? That is how occupation and age is very, very important. Right? I've told you army personnel because he's young male with now this patient has come with pain and swelling. And we'll ask him about, twisting injury, you have fallen there, here, somewhere. He'll tell, no, I have not fallen anyway, but usually we do this, regular practice of marching and all, probably because of that I was thinking. And when we take the x-ray, this has stress fracture. Very good, Kalai. And then this, what is this? So here, as you see first, what is the impression? There is an arrow mark, that means some fracture is there, right? So this is an example of fracture, long bone. So this is happening in the humerus, neck. So neck of the humerus, that is the proximal humerus fracture, right? So now if you see, this particular patient's age was somewhere around 45 years. And it was a female patient, 45 years, female, and they have come with so and so x-ray. Now what you see here is there is the bone itself is not very, very good. You see this particular bone, the entire bone is good. So this is also a fracture, proximal humerus, right? This has occurred in 55 years female, right? So if you see here, I want, yeah, proximal humerus fracture, need classification, perfect. That is the answer. But here the question is not about the classification name. The question is about whether the bone is same or not. And if you see this x-ray B and x-ray A and x-ray B, if you see the bone here is not good. I mean, the quality of the bone is not good. So this is an abnormal bone. So there is some problem in the bone itself. And here this was also a low force. So low force injury. So whenever there is a low force injury, what you have to remember is there are two types of can occur in case of low force. One is stress fracture. And the second one, I'm waiting, Kalai, for your answer. Low force, abnormal bone, there is a fracture. What do you think this fracture can be named as? Very, very important. So this is an example of pathological. Yes, very good, Helix Soram. This is a pathological fracture. Very good. So this is how the mechanism of the injury is very, very important to diagnose a particular case, right? So we have started with the age, mechanism of injury. Yes, Mirrell score is used for pathological fracture. Very good. So that is how mechanism of injury is important for us depending upon the direct forces or indirect forces and velocity of the forces. You can come up to certain diagnosis. And then comes the most important thing, that is the pain. So this is very, very important. So pain is very important to tell us which site we are dealing with. So first the patient comes with pain, right? So site, which area? Then the side in case of ortho, because we have two limbs, right? Two limbs, two upper limbs and two lower limbs, right? So the side of the pain is very, very important. And then you have to ask the duration of the pain, whether it is a continuous pain, whether it is an intermittent pain. You are very, very important, because depending upon the duration also. So if the patient is having pain in the early morning, as soon as he wakes up, what could be the diagnosis? The diagnosis is inflammatory disorder. If the patient is having pain at the end of the day, so what disorders they are dealing with? Harsh helix, yeah, inflammation. But I'm asking if the pain is at the end of the day. So as our old, your grandmothers, mothers, once they complete all the work and then they come up to the bed and they say, my God, everything now, God, please relieve me of this pain. But they do all the work all the day, and at the end of the day, they complain about this pain. Tuberculars, okay, tuberculars. Okay, this is sudden set where it is night rise. That is because of muscle relaxes at that time. That okay, I take tuberculosis. It's not metabolic. So usually when they say it is at the end of the day, end of the evening, I have your grandmothers. It is a degenerative. But as yes, osteoarthritis. So as Harsh has told, tuberculosis, we usually is night pains or night cries, as they classically describe in case of TB. That is because in TB, what happens is whenever your spine TB, spinal tuberculosis, the muscles are guarded. The muscles act as the complete day so that this spine is straight and they don't let you the pain. But once you go onto the bed, you relax. So once the muscle relax, you have pain. So these are called the night pains or the night cries. But usually you have to remember, whenever somebody is complaining about the stiffness in early morning or pain in the early morning, this this can also be taken as for swelling. Usually at the start of the day is inflammatory, and the classical example of inflammation is case of rheumatoid arthritis and is ankylosing spondylitis. These two, whenever they quote or whenever they want you to answer this as rheumatoid or ankylosing spondylitis, they will give the certain keywords which are called your early morning stiffness, early morning pain. In case of rheumatoid arthritis, it is the joints, that is the appendicular joints. But in case of your ankylosing spondylitis, yeah, which joints are usually involved? Which skeleton is involved? So whenever they say pain in the back, and yes, all joints are a your axial skeleton, especially the SI. You want mnemonic for flexion and extension of IPA and PPP? Rheumatoid arthritis. So we have two deformities. One is swan neck deformity. The second one is Botania's deformity, right? swan neck is flexion of DIP. So always remember this is your swan neck, FDIP. Okay, FD, you know that fixed deposits we do. So remember FD. So once F and D, flexion first with D, then it is your swan neck. The opposite is botanus. So one thing, whenever you get confused with search pneumonia, remember only one. Either remember swan neck or remember botanus. One is easy, you can remember. So botanus, what they usually tell is PIP, no? So BP. So FD and BP. Usually they will try to tell you like that, but remember only one. So first, photogenic memory is very, very important, right? So whenever once you see this particular finger like this is your swan neck. So this is your swan neck. Remember FD, fixed deposit, that is flexion of the DIP. When you want to remember botanus, it is BP. Either remember FD or BP. But if you're getting still confused, remember the swan neck. So this is the picture of it. So it is really like this. The swan neck is like, okay. Okay, FD done. Okay, fine. Thank you. So that is how the pain is very, very important. You have to understand, you have to take the history of which side, and duration. So whether it is an early morning pain, early morning stiffness, or it is an end of the day, or as Harsh has told us, whether this is, only particular in night time, that night cries or night pains in TB. So that is how pain is very, very important. And one more important point in pain is radiation, especially in ortho. You have to ask this question of radiation. So they will come with pain in the cervical spine. How it radiates to your arm. So there you can diagnose it as cervical spine. And sometimes they come with pain in the back and it radiates along the posterior aspect of the leg. So there you can diagnose this as sciatica. Sciatica, remember, it is a symptom like your jaundice in general surgery. It is not a disease or a diagnosis. Sciatica is never a diagnosis. It is a symptom. So now this sciatica, this could be because of the lumbar canal stenosis, or it could be because of the prolapsed intervertebral disc. That is how radiation is very, very important. Pain before fracture pathological. Yeah, sometimes, yeah, there could be some pain which the patient neglects, right? For example, if it is an ABC, aneurysmal bone cyst, it is a simple cyst, right? Until and unless patient land up with fracture, she will not know it is an cyst there, SBC, like the simple bone cyst or the aneurysmal bone cyst. Sometimes they only see when they come with fractures, actually, right? Yeah, sometimes there will be pain, sometimes it is not very significant pain which they have in pathological fracture. So that is about the pain. So you have to ask about the site, which site? Side, very, very important to ortho, and duration of the pain as we have discussed, early morning or night, and then radiation. Very, very important, radiation. And especially in pediatrics, there is certain disease which is called as 𝐒𝐿. As you all know, what is 𝐒𝐿? Clipped fatal femoral epiphysis. Here what happens is the problem will be in the hip joint. Problem is in the hip joint, but the patient will tell you that he's having pain in the knee. So this is a very, very common mistake, usually also done by senior orthopedic. So what they do is, whenever the patient enters into the OPD, they say there is a pain in the knee joint. So that is why in ortho there is a golden rule which you have to remember, that is one joint above and one joint below. So whenever there is a patient who is complaining about pain in the knee joint, should always examine the hip joint also. And whenever there is a patient complaining about pain in the hip joint, always examine the knee joint. Right? So this is how the thumb rule goes in ortho, one joint above, one joint below, because in skiffy, usually what happens is the radiating pain is towards the knee. And they keep you telling about, knee, there's a pain in the medial side of the knee, painful and all. Yeah, adolescents, overweight, Trethoven sign, endocrinal abnormal, everything will be there. I don't say that it is there, but usually uh, we get deviated whenever they say it is a knee pain. So you have to always examine the hip. So whenever somebody is talking about radiation, this could be a probable extra question in the viva, right? So you have to remember this particular uh, disease, it is important in case of your radiation, right? So these are the extra questions which they can ask you in Viva. Like, uh, like for example, if you're talking about, patient is having severe pain in the morning, then they will tell you why you are asking it is morning. What happens if the pain is in the evening, like that? Then you can tell them, see, sir, certain diseases, infection, they'll be in morning pain, degenerative, they'll be evening. Then they'll get impressed, right? So that is the extra edge. And similarly, if you're talking about the radiation, they ask you, can you tell us some diseases which radiates, the pain radiates to knee pain? Then you can tell it is a ski, then they'll be very happy. So these are some extra points, right? So that is about the pain. So these are, in case of ortho, these are certain important things which you have to ask: the side duration. Okay. And then whenever it is, something related to trauma, there will be absolutely loss of movement, right? So usually the patient cannot move his limb, especially in dislocations and fractures. Dislocations and fractures, but there are certain cold cases also. For example, your avascular necrosis. There also there will be certain loss of movement. So you have to examine for this loss of movement, right? So this is still in history. So we have asked about the age, we have asked about the mechanism of the injury, if there is any trauma, then we have asked about the pain. So what is this pain related to? Then we are now asking about the functional loss. So if there is a pain to that patient, then there will be some amount of functional loss. So for example, if a patient has come with the pain in the shoulder, so for example, let us think she has tear in the rotator cuff. Now she's coming to me, she's telling you that, ma'am, pain in the shoulder, and there is a problem in, lifting up my hand like this. Then you have to ask her what are its, disability she's facing. So now she will tell, I can't comb my hair like this, or I can't, put my collar properly up like that, or I can't put my buttons properly. So these are all function, loss of function. I can't comb my, I can't take things above the kitchen, overhead things I can't take. So there you can come to the diagnosis whether it is a frozen shoulder, where complete of the shoulder is lost, or it could be a tear in the supraspinatus where, she can't lift the hand above 90 degrees. Up to here she can lift and drop arm sign. So this is very important history. Once they tell about pain, next immediate leading the loss of movement is the function, the disability they are facing. For example, if a patient is pain in the knee joint, then she will tell, ma'am, I can't walk for a longer distance, I'll sit and start walking. Okay. And then hip joint, they can't squat, they can't cross leg. These are all the functional loss which they tell us. And fine, and they can't bend, they can't take their kid from the door, or they can't bend and, do certain things which are supposed to do in a daily job. So this is very, very important that you talk about the functional loss in case of the history taking, and that depends upon each individual joint, right? And then coming to the swelling or deformity, very obvious, and is sometimes could be a cosmetic reason where the patient, for example, it is a ganglion. So you all know what is a ganglion. It is just a swelling over the dorsum of the hand. You see that that is a cystic swelling, right? And this is a swelling they see on the dorsum of the hand, and they just come running to you. Something has happened, very serious, and they tell you that it is moving whenever I move like this. Then that is because cosmetic reason. They don't have any pain, they don't have any loss of function, nothing else, but only they're unable to see that swelling on their beautiful hand. So sometimes the swelling and deformity, sometimes it is because of the neglected trauma. So can you tell me one deformity which is neglected? So usually it is the malunions. So especially the supracondylar fracture, if you remember. What is the deformity we see? Supracondylar fracture. What is the deformity? Kalai, Harsh, Lex, faster, I'm waiting. It's yes, shock deformity. Of femur fracture? The supracondylar humerus. Yeah, this is the gunstock deformity, cubitus varus. Supracondylar fracture, humerus. Whenever there is a fracture and neglected malunion, it gives you a gunstock deformity. Yes, helix. That is cubitus varus. Okay? So such swellings, deformities they talk about, and then you have to take a detailed history of whether the deformity has started, is it progressing, or it has stopped. All those things you can talk about this swelling, the deformity. Right. So these are the 5 important things for history taking. So one is the age, mechanism of injury, then the pain, loss of movement, that is the functional loss, and swelling or the deformity. The deformity, what you say, first you ask about the appearance. How did it start? When did it start? The duration of it, since when it is there. You will ask whether it is progressing or it is stopped, the progression of the deformity. Again, you will ask the functional loss. What is the problem with that particular deformity is having? Yeah, fist. Okay, fine. The proximal fragment deformity. Okay, that is on the X-ray, I believe. So that is the swelling or the deformity history. So once we complete the history, what is important as is now, whenever you take the history, tell you one very, very important thing. You have to come to a diagnosis. The diagnosis should be there in your head, right? So certain diagnosis, we are dealing with the hip joint, we are dealing with the right side, right? And then you have to broadly categorize whether it is, trauma or non-trauma, whether it is avian. It is all in the head. You're not talking to any, you're not telling to the examiner, not telling to the examiner or someone. It is in the head. So once the history is done, I sincerely tell you that you have to come to one diagnosis, at least one or two diagnosis, right? At least one or two diagnosis should be in your head. Then only you are coming to the examination part. Before that, you're not going to examine anything because you don't know what to examine, how to examine, what are the special tests you put up to, confirm your diagnosis, right? So you have to come to a probable diagnosis at least. So once, let us assume that you have come to a diagnosis and now you are going to confirm this diagnosis by your local examination. So what are the 4 important things which are there in the local examination? The first and foremost in every department as it is there, it is the inspection. So first you're going to see the particular point. So for example, let us take a case. So let us think that we are dealing with the malunion of distal radius. So a patient has come with the some deformity. So there is a deformity in distal radius, and now this deformity you are seeing it on inspection, right? And then you will palpate, then there will be measurements, and then there will be movement. So please remember these 4 things you have to do. One is inspection, palpation, measurements, and movements, right? So whenever they say malunion of distal radius, usually the patient would be of more than 50 years, right? So the patient of more than 50 years, female patient, right? And then you're examining the wrist joint because she has been showing you the deformity and she has told you that there is a trauma which has happened and some treatment has been given to it which was not so adequate, so it has landed up in this deformity. So this is a brief history you have. So after taking the history, you have put the diagnosis as malunion of distal. Now you inspect it. On inspection, what you see? So on inspection, what we see is, what is the first thing which catches a clinician eye is a swelling, right? Rather than deformity, if there is a swelling, we tend to see that first, right? So this swelling we usually see in case of fractures and dislocations and sprains. So if it is a fresh trauma, and if it is a old trauma, this will land up in deformity, like your malunion. So this deformity usually in Colles fracture, what we see, it is a dinner fork deformity, right? It is a dinner fork deformity. It is a dinner fork deformity, right? So first on inspection, what we see, we'll see an abnormal swelling, we can see a deformity. So for example, if you see on this particular image, you can see that there is a abnormal swelling here. So based upon this, you can think this could be a fibula fracture or some ligament sprain in it, right? So this is your inspectory finding. So you will tell the examiner, I have seen that particular patient is having the ankle joint. Swelling is more prominent on the lateral aspect, right? That is how inspection goes. And then most important thing is the attitude of the limb. Now, can you tell me what is the difference between attitude and deformity? Attitude and deformity. So when somebody asks you what is the attitude, you have to tell that is the ease the limb. Ease of the limb. That means that is the position where the patient is comfortably placing his limb. That is called the attitude of the limb. So if you see this particular image, you can see some attitude of the limb. So this patient has put his limb in a particular position, which is not normal, right? So this is, yes, obviously it is to prevent pain. Any mechanism in the body is obviously to prevent the pain, right? Yeah, it is to prevent the pain. It is that position where the patient feel that pain is minimum, right? Usually they will have pain. Yeah, pain. Little comfortable position where the pain is little at a lower side. So what is this? Yes, this is the posterior dislocation where you see there is a flexion, adduction, and internal rotation. So these three things are usually seen in a patient of posterior dislocation of hip. So whenever you see this posterior dislocation of the hip, this type of attitude directly in the OPD or directly in your casualty, you can think that this could be a case of posterior dislocation of the hip. And you can be even more careful. You don't do all the movements like, you will not try whether I can do active movements or passive movements, the measurements, the inspection, palpation, and all that you don't try, because you know that this attitude is because of some dislocation in the joint, probably, and you will directly send the patient to okay. That is how it is important to understand certain things, right? So attitude of the limb plays a very important role, especially in the lower limbs, especially lower limbs. I'll show you one more attitude of the limb. So this is one more attitude. This attitude. So this is a straight limb, but there is some problem with the attitude of this limb. So here, whenever we have gone for X-ray, this is the case of the. So that is how important the of the limb in case of lower limbs. But in case of upper limbs, usually the shoulder dislocation, there will be a particular attitude where the patient will hold the hand with the other hand, right? It will be abduction. The patient cannot adduct. So he will have flexion, abduction like this, flexion and abduction, and he will hold the limb with the opposite hand, right? So this is the attitude of the shoulder dislocation. Yes, this is the anterior dislocation. Before one is anterior, where there is flexion, abduction, and external rotation. This is a case of dislocation. So that is how the hip attitude is very important, and this is the attitude of the upper limb, right? And now if you want to see the deformity, so what is this deformity? What is this deformity? This deformity is, yes, this is the what we are discussing the case, the dinner fork deformity. This is the dinner fork deformity. So usually we see this deformity in case of the malunited Colles fracture, or we can see this deformity in case of fracture also directly in Colles fracture. The patient will come with this deformity sometimes when it is not reduced properly or a severe fracture, right? And what is this? I think Harsha has to tell this. What is this? This is a deformity, right? The patient can directly come with this deformity. There is a flexion of the PIP, right? Whenever there is a flexion in the PIP, what is this called? So can you answer for me? Very good. It is a Botinius deformity. Very good. It is not claw hand. Claw is like this, something. Okay. So that is the attitude of the limb. And then what is shortening? So especially in case of lower limbs, no? In case of lower limbs, whenever there is a fracture or whenever there is a problem in the proximal femur, what we see is we see this. Yeah, Botanius, correct. We see this shortening. So shortening is nothing but the limb gets shortened. So where do you examine for shortening? You will see both the medial malleolus, right? So on the lower limbs, you check for the medial malleolus, for the position of the medial malleolus. If the medial malleolus are together, that means the limb length is maintained. If the medial malleolus is higher up, then this particular limb is shortened. Whichever medial malleolus goes up, that particular limb is shortened. So that could be an indication of problem in the proximal, right? So usually proximal femur will result in this shortening, right? So that is about the shortening. Then skin. As you all know, skin tells us, speaks a lot. So what is this? So this is what I was talking about. So this is your medial malleolus, right? So this is your medial malleolus. See, this medial malleolus has gone up. So this limb is end. And what is the attitude of this particular limb here? Attitude of this particular limb. If you can see, the lateral, this aspect is completely touching the couch. So this is an example of external rotation, right? So there is an exaggerated external rotation. And where do you see this? Faster, where do we see this? Yes, very good, external rotation. This is seen in the IT fracture. So the trochanteric fracture, there is an exaggerated external rotation. Whereas in IC fracture, the external rotation is there, but this is minimal. Yes, very good. IT fracture. Very good, Kala. It is IT fracture. So whenever it's an IT is nothing but an example of extracapsular. So there is no capsule to accommodate. There is no capsule to protect, I mean like prevent the external rotation. So it is completely rotated. Whereas in IC fracture, it is an intracapsular. So there is a capsule which is avoiding it to completely rotate. So there is a minimal external rotation. Understood? And now this is an example of the skin discoloration. So if you see this important ecchymosis here, let's say there is some skin discoloration, right? But this discoloration is very minimal. But what is the problem here is this can be as complicated as a Lisfranc fracture. What is a Lisfranc fracture? Lisfranc fracture is torso metatarsal, right? Torso and metatarsals. The tarsals and the metatarsal, the junction between them. So, foot X-ray, if you see the tarso metatarsal, I think you can see it later. So that is the Lisfranc fracture. So even this minimal ecchymosis, you know, that small skin discoloration, so will speak a lot about the fractures which is inside. So skin discoloration is very important. And this is the exaggerated skin abnormality, that this is the blisters. These are the blisters, and these are very commonly seen in tibia fracture. You can see the X-ray here. So these proximal tibia fractures are very, very noticeable. And this will result in this exaggerated skin problem. This is blister formation, so that the patient will be operated for a longer duration, right? And there are certain other treatments that have to be followed instead of, you know, regular plating or regular nailing because of this skin discoloration. Because in ortho, the most important is soft tissue and the skin, because the bone is protected by the soft tissue and skin. You can fix the bone in any way. You will put all the plates, nails, and screws, but this should not damage the soft tissue out. If the soft tissue is damaged after putting, the whole bone gets infected, right? So you have to be very careful when dealing with orthopedic problems, as there's or skin discoloration. This is very important for the treatment part also, right? So this is the skin discoloration. Once, let us a quick review. So in inspection, you talk about abnormal swelling, whatever swelling very evident, and then you speak about the attitude of the limb. Then you talk about the thinning, and then you talk about the overlying. These are the important points which you have to see in inspection. And then comes the palpation. So palpation is nothing but again confirmation of your inspectory findings, right? So how do you confirm them? So first I have told you swelling and deformity. So whenever there is a swelling, you will suspect that some bone has been fractured. So how will you confirm it? Now what you do is you touch the bone and see whether it is problematic or not. So that is called as bony tenderness. So this you have to not get confused with the soft tissue tenderness. So as you all know, there will be bone, and over that bone there will be soft tissue, right? So you have to go to the bone and then touch it. The bones are all superficial. You touch them until and unless the patient is obese and all. So this bony tenderness, the local bony tenderness should be elicited, and this will confirm there is a trauma, that there is a fracture or dislocation. And once you see that the bony tenderness is there, still feel that there is a fracture, you have to check for the entire bone. So entire bone you check, and you check for any bony irregularities are there. And then you can even check for abnormal movements. So what are these abnormal movements? For example, think this is a limb. So this is the foot, lower limb. This is the foot. This is your entire limb. And when you rotate your limb like this, so the entire limb is rotating, right? So if I'm rotating my forearm, my arm is moving somehow. And whenever this transmitted movement is absent, and you can feel some abnormal movements at the fragment, then you say that there are abnormal movements which are present, right? So the transmitted movements are the foot. If you move the foot, you can see the entire limb is moving, right? So this continuity of the bone should be maintained. So whenever there is a fracture, whenever there is some problem in between, there will be bone irregularity, there will be loss of transmitted movements, and you can feel some abnormal movements at the fractures. For example, if there is a fracture of the radius, for example, near my watch, there is a fracture. Here, what you can see is some abnormal movement. So instead of the bone moving at the joints, you can feel some movement which is occurring there. So these are the abnormal movements. Yeah, any movement not only at the joint, even in the mid of the arm or mid of the forearm, like that. Other than joints, when whatever the other movements are all abnormal movements, right? And what is crepitus? Crepitus are those small crackling sounds which you hear while moving, or the abnormal movements of fragment, right? So whenever there is something abnormal, things happening inside, so for example, fracture, so you can hear that small fragments which they'll give us some crackling sound, as crepitus. And in case of osteoarthritis also, if there are a lot of loose fragments which are present, and if the joint is damaged, the cartilage is damaged, when you do flexion and crepitus. So crepitus is felt. Crepitus, you feel it, you put the hand. Sometimes you can hear also, but usually it is felt, right? So these are the palpations. So first inspection you see, and you note down certain points, and now you confirm those points, such as if there is a swelling, whether it is a fracture. If it is a fracture, with tenderness is present. If it is a dislocation, you can feel those abnormal, no movement at all. For example, if there is a shoulder joint dislocation, the patient cannot do the adduction. So you will test for the adduction, and he will not do. Instead of that, he will do exaggerated external rotation, like that. So there will be some, and if there is a fracture between radius and there are some movements which, right? And I've told you what is transmitted movements. Whenever the arm is completely connected, so if I move this arm completely, we can move like that. But when I'm moving this wrist, only it's part of the wrist and it's part is moving, entire movement, that entire arm, there is no movement. So then there will be loss of the transmitted movements, right? So this is all have to see in palpation. So this is like, it is eliciting the medial joint line tenderness or the lateral joint line tenderness. This is how you elicit in case of osteoarthritis. This is the eliciting the tenderness. You press that important point where the patient is telling you that this particular area I have pain. So you will press that particular area, see whether it is from the soft tissue or it is from the bone directly, the local bony tenderness. And then once you're finished with the inspection, then palpation, you're half done. This is measurement is something very important, especially in the lower limbs, especially in the lower limbs. So there are two important measurements which you can take. One is the longitudinal measurement. So this is again to know whether there is a shortening of the limb. So you will measure and tell the particular examiner. So this has been shortened. So this shortening is measured by so and tape from anterior superior iliac spine to medial malleolus. Usually the measurement which we take on both the sides. But before that, you have to see that both are at the same level. Both anterior superior iliac spine at the same level. So this is how you tell there is a shortening or not. So bony point measurement. The measurement is mainly at the bony point, right? And then circumferential measurement. So these are the circumferential. You take a mid thigh or mid calf. Why this is mainly because of the calf, the calf and mid thigh. So this is mainly to know the wasting and atrophy. So atrophy and wasting, right? To understand what is atrophy and wasting there, you will tell whether there is a mid calf wasting. Longitudinal measurement is mainly the shortening of the limbs. It will tell how much the limb is shortened, right? So that is about the measurement. And finally, most important is movements in case of. So movements, there are two types of movements, active and passive. Active is done by the patients themselves and passive done by the clinician. So this also decides what is the problem in that particular joint. So in case of active, so for example, there is a this. I've told you that there will be a loss of movements, right? The patient will be not able to adduction loss, right? Case of shoulder dislocation. Okay. So like that, what active movements are usually done by patients. Depending upon the joint, you will tell them to do so and so movement. Passive movements, it is done by the clinician, right? So this passive movements again tell you that whatever is the problem. So for example, stiffness of the joint. So here what happens, the patient also cannot do, the clinician also. Both active and passive movements are lost. So this is the stiffness of the joint. In case of myositis ossificans, there will be restriction. So for that, you have to know whether there is only active movements or a passive movement. So you have to examine for the movement. Measurements and movements are very, very important. Then special test. For each examine or diagnosis, there are certain special tests which will learn uh, depending upon the joint. For example, we are dealing about the hip. So you have an active SLRT. So straight leg raising test is your special test. If for your PIVD, that is prolapse intervertebral disc, then you go for passive SLR, right? You go for passive SLR. And for example, it is your rotator cuff. There are various tests, your MT-CAN test, right? You do like this and do the test, right? MT-CAN test. Then you have your ACL. Then you do your anterior draws test. So like that, there are various tests which we learn in detail whenever that particular uh, joint. And now comes the most important point, that is the probable diagnosis. So always you have to start the probable diagnosis with the age. So you will tell that particular patient age. For example, she's some 65 years old male. What is your diagnosis? So if you think it is a malunited Colles fracture, so that is your diagnosis. Malunion is your diagnosis for a Colles fracture. So as we know, wrist is the site and you can tell whether it is a right or left, and very important is with or without, right? So here the malunion itself is a complication. So you will tell it is a malunited Colles fracture, right side, right? So malunion is the complication. So for example, if you want to tell about the AVN, so it is itself is a complication. So now you want to tell only about the fracture. So you want to tell there is a patient of patella fracture, fresh patella fracture. Then you can tell with or without complications, such as, any nerve injury, any blood vessel injury, like that. So this completes your complete diagnosis. So you have to always start with the age, then go up with the, gender, the diagnosis, side very, very important. And then you have to tell whether it is with the complications or without complications. So this malunion, AVN, 𝐒𝐿𝐻 contracture, any nerve injury, vessel injury is there, all these comes the is your probable diagnosis. And how you confirm the diagnosis? You will go for investigation. What is the important investigation? So it is the X-ray, or you can quote for CT scans or MRI scans, right? Right. So you can take the help of all the invasive diagnostic techniques, and then you confirm the diagnosis, which is your definitive diagnosis, right? So that is how, and these complications are very, very important to understand the diagnosis and tell them whether it is actually related with the complication or you're going to deal later with that particular complication, right? So that is how we diagnose a case. So the take-home points in ortho. The first is always the patient diagnosis starts from the age and golden rules: one joint above, one joint below. You have to examine, right? That is very, very important. One joint above, one joint below, and always compare, because we are blessed with the two limbs, two upper limbs and two lower limbs, right? So you can compare it to the opposite side. Very, very important, right? So these are certain take home points. And then X-ray, take use, very, very important. So whenever you're ordering for the X-ray, always take two, AP or oblique, certain special views for certain special cases, right? Always, always, always write the full diagnosis. You're taking a case, diagnosis should be full, right? Side and the complications are very, very important, and you should stand, right? And that is about the in general about any orthopedic case you can deal. So this is our clinical library, which is there since a longer time. We have introduced it in MEDED 2.0, and in this we have various cases which are incorporated depending upon the departments. For example, if you go for orthopedics, you have various other, you can deal about non-union, malunion, nerve injuries. So you click upon that particular topic and you will get how to take a case, is the things you have to ask for that particular case to conclude, right? So I hope this will be very, very useful for you all. And this is very, very important, guys. Cracking the seat is, but clinicals are equally important. Okay, hope you have enjoyed the class, learned little bit of taking a case and how to diagnose a case. See you all in the next class. Okay, take care. Bye bye. Good night. Any doubts you can. Yeah, thank you, Kalai. I have to really thank Kalai and Helex, Harsha. Thank you so much. Yeah, see you all in the next class. Good night. Bye. Okay, any doubts and any queries, I am available on Insta, Dr. Alekhya Ortho, right? Or you can meet our team members. Okay, any doubts, anything related, you can ask on particular Instagram page. Okay, thank you so much. Bye. Next topic, I will update it. It is usually examination of the individual joint. So now from now, because we have a general uh, uh, talk about all the joints, now we will know how to examine a shoulder joint in particular, how to examine an elbow joint in particular, and hip. Okay, so this is very important, which will be asked in your. So after that, we'll have peripheral nerves, examination of each nerve. Okay, so there are certain classes, some 5 to 6, and then